the families of the Chang Forum, and he is one of the most supportive colleagues to the Chang Craniofacial team in the ICC. Professor Fayyaz's team has performed more than 26,000 free cleft lip and palate surgery all over the world, including Rwanda, Mexico, Philippines, and Morocco. In his visions, he is going to establish a new hospital at Lahore, Pakistan, where free surgeries will be provided to those who in need, such as cleft lip and palate, craniofacial deformity, and so on. And currently, Professor Fayyaz is the president to lead Pakistan Association of Plastic Surgeons. So today, Professor will present the topic of a Pakistan comprehensive fistula classification and the management of palatal fistula. Can't wait to start. Professor, please.
Thank you very much. I'm very much obliged, and it's my honor to present our experience at the Chang Forum. And so if we see the history of Pakistan, Professor Rolf Balaxma, he visited Pakistan in 1948 and he stayed here till 1954. And he established United Christian Hospital in Lahore. And when he went back, he trained Professor Samuel Nudaf, who is the teacher of the teachers. And my first workshop for the cleft lip and palate was in 2002. And then the journey never ended, 2004, 6, 8, 10, 12, 14, 16, and 19. And this is the picture of the first workshop I attended. And Professor Philip Chen, Dr. Kaifang Gung, and Professor Chang, and Professor Jure Chen invited me and other colleagues for a dinner at the golf club in Taipei. This is the second forum I attended, and we are presenting a souvenir to Professor Nudaf. And we founded a Cleft Lip and Palate Association of Pakistan in 2003, and our slogan is helping them smile and speak. This is the hospital where we work now, and we started this facility in 2008, and so far we have done more than 43,000 cleft lip and palate surgeries in Pakistan and Afghanistan. So we developed a new classification, Pakistan Comprehensive Fistula Classification. And it's a novel scheme and algorithm for management of palatal fistula and dehiscence. The paper was published in 2019 in PRS. So whenever we repair a palate, we have two objectives. We want to create a barrier between the oral and the nasal cavities, and we want to have good speech production. Generally, we will operate at 9 months, and then depending upon the patient presents to us. For the maximum age, we don't have any limit. As Professor Nudaf described, that even if you achieve a barrier between the oral and the nasal cavities, you have helped your patient. So we have had many patients 50 years old and more than 50 years old. The complication can be immediate, post-op bleeding, airway problem, late maybe infection, dehiscence, fistula, velopharyngeal incompetence. And then the better term is palatal fistula. Some people would use oronasal fistula. It's not a better term. Labionasal fistula is because of the lack of nasal floor reconstruction during complete cleft lip repair. Alveolo-palatal fistula can be called intended fistula, absence of complete closure of the nasal layer around the alveolus. Palatal fistula is usually a hole in the suture line. How we can examine the palatal fistula? We can use simple illumination by nasopharyngoscope. The fistula may be plugged to see the speech, and we can record the speech sample before and after. If hypernasality is decreased after plugging, then it is due to the fistula. But if the hypernasality is persistent, then it means that the muscle function is not good, and we have to do another surgery to improve VP function. Our policy has been usually wait for 9 months after previous surgery, because the edema gets settled and the vascularity around the edges of the fistula gets improved. So why do we classify anything? Because we want to have better understanding of the problem. We want to have good documentation, which can be shared easily, and then the management plan can be devised. There have been different classification during different time periods: pinpoint, slit, oval, total dehiscence. Professor Ohsumi from Japan, grade 1 less than 2, 2 to 5, more than 5. Dr. Muzaffar, he said small less than 3, medium 3 to 5, and more than 5 are large. The prevalent classification mostly used around the globe is Pittsburgh classification, and they start from the uvula, soft palate junction, hard palate junction of the primary and secondary palate, lingual and labial alveolar. Our colleague from India developed a classification longitudinally placed transverse, and he described the location of the fistula, and he also coupled with difficulty index. We encountered many of the fistulas during many years, which could not be categorized by any of the prevalent classification system. Some of the fistula were placed too far laterally or more anterolaterally. Fistulas were multiple, and the fistula was traversing into more than one region. So what is the purpose of a new classification? We want to know where the fistula is located. Is it single or multiple? The size of the fistula, velopharyngeal competence, and we can make a plan to help the patient. So the fistula may be large size, which may be subtotal because of the damage to the pedicle. Fistula may be lateral in the hard and the soft palate. It may be multiple. There may be partial or complete dehiscence. We want to see the function of the palate and then the problem with the reconstruction. So our scheme has been based on location, size, velopharyngeal competence, and dehiscence if there is any. This is our classification. We divided into 3 types. Midline, we started from the anterior portion, and we say labial and lingual because the management is same. We both call it M1. We divided the hard palate into 2 portions, anterior half and posterior half. M2 is in the anterior half, M3 is in the posterior half, M4 is the junction of the hard and the soft, M5 in the soft palate, and M6 in the fistula. Then the fistula on the lateral side, if it on the left side, we call it LA. If it is anteriorly placed in the posterior half of the hard palate, we call it LB. Similarly, RA, RB, and if these are the soft palate, we can call it RC or LC. Midline fistula are usually within 5 millimeter of the either side of the midline. Lateral, when it is more than 5 millimeter away from the midline. And subtotal fistula, when anterior portion of the hard palate mucosa is lost because of the damage to the pedicle. It may be unilateral or it may be bilateral. So these are all the midline fistula. Then the lateral fistula, LA, RA, RB, RC, LC, LB. Subtotal fistula, right, when the right pedicle is damaged, 50% or more of the anterior hard palate mucosa has been lost. When on the left side, and it may be bilateral when both the pedicles have been damaged. So subtotal left, subtotal right, subtotal bilateral fistula. Dehiscence, when it involves the uvula, we call it D1. When it extends into the soft palate, we call it D2. When it extends to the posterior half of the hard palate, we call it D3. And anything anterior to that is D4. So later we describe the size as 1 to 5 is H1, more than 5 to 10 is S2, more than 10 to 15 is S3, and more than 15 is S4. So H1, S2, S3, S4. We have included the function of the soft palate along with the fistula management. V1 when the palate length is good and the function is good. V2 when palate length is good but the function is poor, so we have to repair the palate. V3 when the palate length and function both are poor, so we have to add tissue to the palate. Then the fistula may be single or it may be multiple or fistula adjoining region when it involves more than one region. If the fistula is single, we will write it as F. If the fistula is more than one, we will call it multiple fistula, and the anterior most fistula will be called F1 and then F2 and F3. Fistula adjacent region, when it may be involve M2, M3 or even M2, so we will write M2-3. Fistula M2-3-4 means it involves M2, 3 and 4 regions. Multiple fistula, subtotal bilateral, M3 in the hard palate in the posterior half, in the posterior half, and a fistula in the soft palate. This fistula cannot be described by this classification, so we have to use this classification to exactly describe the location of the fistula. M3, 4, 5 involving posterior half of the hard palate junction and the soft palate. Starting from M2, M3, M4, and 5. Multiple fistula, M2 and M4. Lateral fistula, LA. Lateral fistula on the left side, LB, because it is in the posterior half of the hard palate. In the soft palate on the right side, it is RC. Subtotal fistula on the left side. Subtotal fistula bilateral. Dehiscence involving the soft palate. Dehiscence involving the posterior half of the hard palate. Dehiscence up to the posterior half of the hard palate, but the left side has been damaged more, so we call it D3-L because pedicle on the left side has been damaged during the initial surgery. D4 R because on the right side almost all the tissues have been damaged. It's almost complete dehiscence with more loss of the tissue from the right side. So any classification palatal fistula should provide information about detailed anatomic description of location, size, and provide guidelines with more emphasis on functional imbalance of the palate for the palate repair. So our algorithm covers every fistula of the palate. It can enable the surgeon to achieve good function of the palate and not just closing the hole. So we will discuss the management of the midline fistula. So if it is in M1, any size, we can close the nasal layer by turning flap, and we can close it by buccal sulcus mucosal flap. We take a flap from the buccal sulcus and we bring it to cover it. Then M2 and M3, we can use by mucoperiosteal flap. M4 and 5, we have to do the palate repair. Fistula in the M2 and the anterior half of the hard palate. So we just closed the nasal layer and we raised both the mucoperiosteal flaps and brought it in the midline. And after 6 months, fistula in the M2 region. So we just close the turn-in flap for nasal layer closure. And then we are going to raise the buccal sulcus mucosal flap. Because of the alveolar cleft, this flap can reach to the defect. So it has been sutured, and then after 6 months. Fistula M1 and M2 region, we close the nasal layer and then we use buccal sulcus mucosal flap to cover it. M3, 4, posterior half of the hard palate and junction of the hard and the soft palate. We close the nasal layer, and then we raise both mucoperiosteal flap and we sutured in the midline. 24 hours later, after 1 week and after 3 months. Then we added a pharyngeal flap to lengthen the palate, and this is the picture after the pharyngeal flap. M5, we did the palate re-repair. We closed the nasal layer and then we raised both mucoperiosteal flap and we closed it. The patient did not turn up for the pharyngeal flap. M4 and 5, so we just make a slit over here. We close the nasal layer and we raise the pharyngeal flap. And so after 6 months, M3, 4, 5, so we close the nasal layer, we raise both mucoperiosteal flaps after 24 hours and then after 3 months. M2, 3, 4, 5, just only the uvula has been sutured in the previous surgery. So we just revised the palate. We did the palate re-repair. The lateral fistula, if it is in the very small size, we can use the contralateral mucoperiosteal flap. Mostly the contralateral mucoperiosteal flap can cover the most of the defect. Otherwise, one can use buccinator flap or one can use tongue flap. This is LA. So this is the defect over here. So we mark the defect. So we will close the nasal layer and then we will use the right mucoperiosteal flap to cover the suture line of the nasal layer closure. So we have developed the nasal layer. We have closed the nasal layer. Both the flaps have been raised. Then we dissected the levator. We sutured the levator as far posteriorly as possible. And then we always do the dissection of the pedicle on both sides to facilitate movement of the mucoperiosteal flap. So the right flap has the right flap is covering the suture line of the nasal layer closure. So we started from here. We ended up here. In between, we also improved the shape of the nose by doing the alar elevation. Lateral fistula on the left side in the posterior half of the hard palate, nasal secretion coming into the oral cavity. This is the defect. So we developed the nasal lining. This is our plan, nasal lining, and we will use the right flap to cover it. So the pedicle has been dissected widely and it is covering the defect on the left side. So this will epithelize on itself. So we started from here and after 6 months, it went very well. Somebody had already done the pharyngeal flap. The same type of fistula, but on the right side in the posterior half of the hard palate, the defect. So we will use the left flap to cover the suture line of the nasal layer closure. So we will close the nasal layer and we have raised the left mucoperiosteal flap. We have dissected the pedicle. And then we split the soft palate because the palate was short and we are going to add a pharyngeal flap. So we have dissected the levators. Nasal layer has been closed and the pharyngeal flap has been elevated from the posterior pharyngeal wall. It is being shifted anteriorly. So it is being sutured in the split soft palate. It has been sutured. So the levators have been sutured over the base of the pharyngeal flap. The left flap, the pedicle dissected, is going to cover the defect. So the left flap is covering this defect. The pedicle, you can see, it will be covered by gelatin foam. And after 6 months, it went very well. Fistula in the right side of the soft palate. So we raised the pharyngeal flap in the same state and we closed it. Multiple fistula in the midline, they are quite easy. We just do the palate tree repair. Nasal layer is closed by turn-in flap and then we do the palate tree repair. Fistula in the M2 region, M3 region, and there is the dehiscence of the uvula. So we did the palate tree repair in the first stage. And in the second stage, we added a pharyngeal flap to lengthen the palate. Multiple fistula M2, M5, and dehiscence D1. So M2, M3, and M5, and dehiscence on the right side. So this is our marking. These are the 3 fistula. So we just made incision on the right side. On the left side, we did all the dissection from the medial incision. So we have dissected the pedicle on the right side. Then we dissected the levators on both sides. Then we split the nasal mucosa. We are going to raise the pharyngeal flap. Pharyngeal flap has been moved 180 degree anteriorly. The donor defect is being closed. Donor defect, we usually close it by running continuous suture. Then we sutured the levators over the base of the pharyngeal flap. So we can see the levators over the pharyngeal flap completely sutured. Then we lengthen the oral part of the soft palate. And this is after 2 years. Subtotal fistula, where because of the damage to the pedicle on one side or both sides, usually if it is on right or left, we can use the contralateral mucoperiosteal flap. If both the pedicles have been damaged, then we have to use tongue flap or buccinator flap, or we can use another technique I will show at the end of my presentation. So this is subtotal fistula on the left side. We close the nasal layer. We usually go make incision up to the bone. We shift all the nasal mucosa medially. And then the right flap has covered the defect. This is after 2 months. Subtotal right. So this is the defect. We can see the marking of the defect. Almost this much tissue has been lost. So we just developed the nasal layer. All the tissues on the right side will be used for nasal layer, and we will raise the left mucoperiosteal flap, and we will widely dissect the pedicle. So we have closed it. The pedicle has been dissected. This is after probably 3 months, and then we added a pharyngeal flap to lengthen because the palate was quite short. So we started from here after the pharyngeal flap, and this is after 6 months when we did the pharyngeal flap. Another patient with subtotal fistula on the right side. So this much is the defect marking of the for the nasal layer. We will use the left side of the left mucoperiosteal flap to cover the whole of the suture line of the nasal layer closure. So the left flap has been raised, and this much tissue all will be used for nasal layer closure. So tissue for nasal layer closure, nasal layer has been closed. The pedicle has been dissected widely, so the flap can comfortably reach the right side. So nasal layer completely closed, and the flap has covered the suture line of the nasal layer closure. This is after probably 24 hours after surgery, after 2 weeks, then after 6 months. Another patient, subtotal fistula on the right, subtotal right, and we covered it with the left mucoperiosteal flap. This is a very large fistula, and this much is the defect, marking of the defect. So we are going to use the left mucoperiosteal flap to cover it, and pedicle has been dissected, and we will make incision up to the bone on both sides, and we will shift whole of the nasal tissues to the midline to close it. So the nasal mucosa has been closed. The right flap is just being lengthened by a back cut. The left flap has reached to the right side. So this is after probably 1 week. This is after 3 weeks, after 4 weeks. So we started from here and ended up here. Subtotal bilateral fistula. This much is the defect. We use the tongue flap. This is for the nasal lining. So nasal lining is being developed. We have closed the nasal lining. We use the tongue flap, closure of the donor site over the tongue. And then we usually detach after 2 weeks. The flap has comfortably covered the defect. This is a very interesting patient. We operated her in Kabul in Afghanistan for the tongue flap, and the detachment was done at Lahore. Bilateral subtotal fistula, midline fistula in the M3 region in the posterior half of the hard palate, and fistula on the right side of the soft palate. So this is the subtotal right, and the size is probably more than 30 millimeter. Midline fistula M3 and lateral fistula on the right side of the soft palate. When we examined the patient, the tongue was not that mobile. So in the first stage, we just released the tongue. In the second stage, we closed the nasal layer. The nasal layer is being developed and being closed. The nasal layer has been closed. Then we took a pattern of the defect and put it over the tongue. The tongue was attached. This is after 3 weeks. When we were planning for the detachment of the tongue, we were very confused how we can cover the fistula in the midline and the fistula on the lateral, right lateral side. So what we decided to take some extra tissue from the tongue to cover both the fistula. So the donor defect has been closed, and we put the extra tissue for the midline and the lateral fistula, but the portion of the flap became dusky, and a very distal portion got necrosed, but it healed uneventfully. So this is the complete flap taken. So this was the subtotal bilateral fistula, the midline fistula, and the fistula on the right side of the soft palate. So by an extended tongue flap, we were able to cover almost more than 70% of the palate. Dehiscence. If there is a simple dehiscence, we can do the palate re-repair. We did the palate re-repair, but the patient did not turn for the pharyngeal flap. Dehiscence, extending up to the posterior half of the hard palate. Left side has been damaged more. So this is the pedicle. So we will use most of the tissue on the left side for the nasal ear closure, and right flap will be used to cover the suture line of the nasal ear closure. The nasal layer is being developed, and we have closed the nasal layer, and we have dissected the levator and sutured as far posteriorly as possible. And then the right flap is covering the most of the defect. This is after 3 months. After 3 months, then we added a pharyngeal flap in the next stage. So we started from here. In the first stage, we did the palate repair, and then by adding a pharyngeal flap, everything was closed successfully. Dehiscence on the right side, because the right side has been damaged very badly. So we are going to use the turn-in flap for nasal layer closure and the left flap for the oral layer cover. So we will use this tissue. This flap will be raised as over here, and the underlying tissue will be undermined to close the nasal layer. Pedicle has been dissected widely, and it has covered the most of the suture line after 24 hours, and then after 3 months. This patient did not turn up for the pharyngeal flap. D4R, almost whole of the palate has dehisced, but the right side has been damaged very badly. So this is the extent of the defect. So we used almost all of the tissue on the right side for the nasal layer closure, but on the left side, we first raised the left mucoperiosteal flap. The pedicle was dissected, and all the underlying tissue were undermined medially, and we closed the nasal layer. You can see the pedicle dissected, and the flap is going to cover the suture line of the nasal layer closure. So this is at the end of the surgery. This is the pedicle, and this whole area was covered with gelatin foam. And this is after 3 months. Then in the next stage, we added a pharyngeal flap. So we started from here and ended up here. This patient was operated by one of my friend, Dr. Fernando from Brazil. Almost total loss of the palate. So he used the almost all the tissue for the nasal layer closure. So the nasal layer has been closed. And then he used the vaccinator flap from the right and the left side. The left flap was placed anteriorly. Right flap was placed posteriorly. These are the buccal fat pads protruding. And this is after 6 months. Over the last 5 years, we have developed a new technique to close the anterior palatal fistula. This patient was operated by one of our friends in Pakistan. That's why I have the picture pre-operative and the end of the palate repair. But both the pedicles have been damaged on both sides. So we ended up a fistula like this. If we go in a routine, we will develop the nasal layer like this, and we will close the nasal layer, and we will use a vaccinator flap, or we have to use a tongue flap, or if the patient is in Chang, they will go for free flap. But usually this sort of fistula will not end up in Chang. So when we put hook over here, we saw 2 mucosal rugosities, large swellings on both sides. And these swelling, these are very adherent. We had to use knife to elevate both the swelling. And then we unfolded the tissue. So the left flap is almost reaching the anterior end of the maxilla. And then we did on the right side, and the right mucoperiosteal flap is also reaching up to this level. Please remember, there is no pedicle in this patient. Pedicle have been damaged. When the mucoperiosteal flap have been lengthened, then we develop the nasal layer. We go up to the, we incide up to the bone. So the tissue from the right side is being moved to the midline, tissue from the left side is being moved to the midline. And then nasal layer is slowly being developed and being closed, completely closed. And then we switched both the mucoperipheral flap in the midline. On the left side, there was defect over the alveolus. So we raised buccal sulcus mucosal flap. This is the buccal sulcus mucosal flap, switched and attached to the tip of the mucoperipheral flap. This is after 1 week. This is after 2 weeks. This is after probably 2 years. So this is after 3 years. Another patient, fistula on the left side. We closed the nasal layer, we elevated the flaps. The right flap has comfortably covered. Another fistula anteriorly, we used the mucosal cavity to lengthen the flap. It has completely covered. Again, fistula on the anterior side, we close the nasal layer, and then by unfolding the mucosal rugosity, the flap was lengthened. Again, a large fistula over here. We use the same technique to close the fistula. Another fistula starting on the lateral side from RA to RB, from the anterior half to the posterior half of the hard palate. So we lengthen the both mucoperipheral flap by unfolding the mucosal rugosity. And then this is the picture after 2 years. Another patient, we use the same technique to completely close the fistula. We have operated 20 patients and we have complication in 2. This was again a subtotal bilateral. The blood supply in this flap probably was not that good. So we ended up with a fistula in the midline. But if we compare with this, and without using any tissue from the different side, so the learning curve in palatal fistula is quite long. We need to classify the fistula, and we need to note the location, the size, and the vilopharyngeal status. And then we devise the plan, and then the proper execution can help the patient. So this algorithm provides practical solution for all palatal fistula with successful outcome if followed in letter and spirit. So I'm very much thankful to my friends from Chang, Professor Philip Chang and Kai Feng, whom they visited us in 2004, and then in 2007, and Professor Professor Ian Jackson, Professor Langiolo, Le Hoi Lin, they visited us in 2005. And then Professor Lowe, Professor Philip Chen, Dr. Frank, and I'm just forgetting the name, Liao. And then Professor Philip Chen in 2015. So based on this experience, with the help of many friends from all over the world, I have written a book with 110 chapters, and 54 chapters have been written from Pakistan, India, Philippines, Indonesia, Australia, Taiwan, Egypt, Netherlands, Italy, UK, Ecuador, Guatemala, Nicaragua, Peru, Paraguay, Brazil, and USA. And 56 chapters were written by me. And this just took 3 years to complete the book. The whole of the book has been uploaded at the Springer Meteor, and we are expecting that the book will be published by February or March 2022. So thank you very much for your patience. And I feel literally honored that I was trained at Chang, and today my presentation for this forum. And I'm very much thankful to all my teachers, Professor Lowe, Professor Philip Chen, Professor Yuri Chen, and all my friends at the NUDAF, especially Rebecca, Linus, and all my friends. I am very much grateful. Thank you very much for your patience.
Okay, thank you, Professor Fayyaz, for your wonderful presentations. Congratulations for your new textbooks releasing, and I think the very wonderful color photos were collected in your new books. I'm so amazed and very surprised for such a great work from your presentation. Yeah. In my very poor experience as a cleft surgeon, actually, I have not seen so difficult cases before, even so far. According to your category and classification for the cleft palatoplasty, I'm not sure because you perform very quite nice the repair method and even in the cases without the pedicles. Yeah, sure. Would you like to use maybe the free flap for such a great hole in the palate for those cases without a pedicle, yeah, cases? What is your opinions?
Can you repeat the question, please?
Yeah, I just wondering, would you like to use the free flap to repair those cases with the big hole and no pedicle available in the palate? Yes.
Yeah. The last case is when I because when the pedicle has been damaged previously and the present surgeon does not know the pedicle has been damaged, so the best way would be to make a lateral incision in the region of the pedicle and try to see the pedicle. If the pedicle is available, then we can raise the mucoperipheral flap anteriorly. If the pedicle is not present, then on that side, the flap should not be raised from the anterior side. We should use it as Longenbeck. The contralateral mucoperipheral flap can be raised and the pedicle can be dissected widely to cover the defect. If the both pedicles have been damaged, then the better would be to close the nasal layer by the residual tissues and use a tongue flap or buccinator flap or a free flap. That's my opinion.
Okay, thank you. And I'm so surprised you can always to divide it and to repair the nasal side so adequately in your own cases shown in this presentation as well. Okay, we have some questions from the audience. The first one is from Ecuador, Dr. Edward. His question is that when do you decide to use the local tissue of the palate to repair a fistula? And when do you decide to use flap from a side other than the palate? Yes, please.
In most of our cases, over the years, we have become more comfortable to use the tissue from within the palate. The first thing I would like to share with my colleagues is that if there is a fistula, we need to wait at least 6 to 9 months to close the fistula because we have to use the tissues around the fistula for the nasal air closure. After 9 months, the tissue edema gets settled, the vascularity gets improved. So if we can dissect the pedicle, the one flap can comfortably cover the suture line of the nasal air closure. Only in subtotal bilateral patients, we are forced to take tissue from the buccinator flap or the tongue flap. I have never used a free flap for my palate repair because we can comfortably do with local tissues, buccinator flap or tongue flap. But in most of the cases, many of the colleagues, they find difficulty to dissect the pedicle. They find difficulty to close the nasal layer. Nasal layer closure is practically, literally very, very easy. The only thing that you have to make incision deep up to the bone, anterolaterally, and then you move all of the tissues to the midline and suture the nasal layer, and then you can use contralateral mucoperiosteal flap or buccinator flap or tongue flap, depending upon the tissue availability. But generally, if one flap is there, we do not need to take tissue outside of the palate.
Okay, thank you, professors. And next question is from Andrews Urago, Dr. Uragos. Okay, so for the preferred suture material for those patients you have shown in your presentation, why continuous suture in some patient? And what is his post-operative treatment plan, such as feeding and cleaning technique? Yeah, please.
We already have published a paper in 2018, continuous suture in the primary palate repair. And generally, when we repair a complete unilateral cleft palate, generally we use only two sutures. We use Vicryl 3.0 and Vicryl 4.0. 4.0 for the nasal layer and 3.0 for the oral layer closure. If we do bilateral complete cleft palate repair, we will need 3 sutures. The only thing, when we use the continuous suture, it saves time and suture. By doing interrupted suture, you have to use more time and you have to use more suture. I still remember in 2009, when Professor Lowe was also here in Pakistan, we had one friend from USA, Dr. Joe Malakar, and he used 18 sutures for one palate repair.
Okay.
Normally our team, when we do the palate, generally we use only 2 sutures. If it is only soft palate repair, we will use only 1 suture. So
okay.
Generally using continuous suture, it is more comfortable. We even close the donor defect in the pharyngeal flap by running continuous sutures.
Okay. And the further question is how is the bone grafting taken in patient with anterior vestibular in the tongue flaps?
Pardon?
How is the bone grafting? The bone grafting taken? Yes.
Yes. Generally, we have a policy. In most of the areas of the world, they will have a fistula in the anterior palate and they would close it when they do the alveolar bone grafting. But generally, we have a policy for many years that we always close the nasal layer during lip repair. And then when we do the palate repair, there is no fistula under the lip. So whenever we do the tongue flap, the bone grafting is not that difficult. We just do as other alveolar bone grafting techniques like in unilateral palate or bilateral palate. That's not a problem.
Okay. From the Dr. Nikolovas, her question is that could you share the experience with the premaxillar lost and how to manage this complication? I have seen many patients in Pakistan. One of the patients, he was operated by a general surgeon, and because the guy was not able to bring the lateral lip flap in the midline, and he excised the premaxilla. In that case, we usually take the help of our prosthodontist and we repair the tissues whatever are available. And when the patient grows, because of our orthodontist was trained at Chang in 2012 and 13, and then we developed the dental prosthesis to make the lip more protuberant, and we joined with the lateral alveolar segments. Okay. And one more question is that Professor Fayyaz, could you instruct how we could take care of this kind of post-operative wound intraorally? Thank you.
Pardon, can you repeat, please?
Yes, how to clean the post-op intraoral wound, how to do the post-op care. Thank you.
Yes, For the post-operative care, we generally ask the patient to take only liquid diet for 3 weeks. We do not allow even semi-liquid or semi-solid, because otherwise they will take solids on the very next day and they will end up with the fistula. And we have a policy that we always advise the mother to give honey to the patient 1 teaspoon 3 times daily. And we ask the mother, do not give water for 15 minutes after you have given the honey. Honey promotes healing. Honey does some microdebridement, and honey promotes angiogenesis, and even honey can do angiogenesis, and it can also provide some nutrition to the wound. So generally our policy is to give honey, even if a patient is going to develop a small fistula. If we are giving honey, by using honey, that fistula usually gets closed or the size is reduced considerably.
Okay, so I think the honey is very good post-operative care materials like that. Okay, the further question is how about the speech functions of the patients after repairing fistula in your experience? Yes.
Yes, we have a dedicated speech pathologist in our team. Whenever a palate patient comes, whether it is a primary patient after the age of 4 years or a secondary patient, all the patient, they report to the speech pathologist. He will examine all the patient and he will give his finding that this patient has been operated and does not need any surgery. We can help him just by speech therapy, or he will give his finding that the palate is short, the palate movements are not that good. You may revise the palate, you can do the palate repair, or he can say, do the palate repair and add a pharyngeal flap. So we feel more comfortable adding a pharyngeal flap during the time of palate revision, because adding a pharyngeal flap at the same time just takes 20 or 30, just more than 20 minutes, something like that. And the palate is lengthened. And we have always a policy to dissect the levators from both sides. And when the pharyngeal flap has been added to the palate, we take both the levators and we put it over the base of the pharyngeal flap, and the levators help the speech very well after the pharyngeal flap has been added.
Okay, thank you. Okay, the next question is Professor Fayyaz. Do you have experience of the buccal pad flap, and how is your opinion about this? Yes, please.
Yes, I still remember our friend from USA, Dr. Joe Malakar. He introduced buccal pad flap in 2009 in Lahore, and Professor Low was also in the OR. And after that, Professor Low, when he went back to Taiwan, he started using buccal pad flap. So far, I have never used buccal pad flap for my patients. But maybe in some difficult patient, I may need it. But generally, I literally believe that the good palate repair, shaving the pedicle, dissecting the levator, keeping the palate at a good length would help more the patient. By using the buccal pad flap, especially in patients with the palate tissue is deficient, it may be quite helpful. But personally, so far, I have not used even in a single patient. And I have never done any sphincter pharyngoplasty for the last many years. We are quite comfortable with the pharyngeal flap, learned from Professor Low and Professor Philip Chen. We are very comfortable with that.
Okay, thank you, professors. Actually, we are so happy and very lucky to have lots of our mentors in this webinar as well. Professor Phil, Professor Robert, and Professor Lunzo Low. So I think all the audience really want to learn from all the masters as well. So I think that first of all, we can invite Professor Phil to give us some comment regarding to the Professor Fayyaz the presentation. So, okay, Professor Phil Chang, could you give us some comment? Thank you very much.
Hello, Dr. Fayyaz.
Hello.
I don't have any comments. I only want to say congratulations to you for the great achievements.
Thank you very much. It's my honor to work with you. And I'm so happy and so comfortable that I learned from your center, and you came to Pakistan many times, and you helped our team and helped my friends in Pakistan. And thank you very much. I'm obliged, always obliged.
Yeah. Thank you for your so gentle. Okay, the next one, may I have the honor to have Professor Robert to give a comment for Professor Fayyaz's presentation. Thank you, Professor Robert.
Professor Fayyaz, thank you again for inviting me to this wonderful event and your book. I'm so looking forward to 1,000 pictures that are going to give us such a great insight into what is happening. It's just congratulations. It's a monumental amount of work, and the whole cleft world appreciates all the efforts that you've gone in. Your classification is indicative of your work. It is broad, sweeping, and focused, and addresses the issues. I will make a couple comments that we all practice in various areas that have unique circumstances, and certainly the practice that you have is very unique. And we will have a great deal to learn from your practice and so many children that are presenting late, and how facial growth is impacted when treatment is early and treatment is late. And I'm very much looking forward to that discussion with you going forward, because I think we can focus our treatments in a way that if we are using early treatment, we're going to do things different than when we do later treatment. And also recognizing the amazing amount of epithelialization that occurs in the older patients that don't seem to get collapse to the same degree that they do when they're younger. And how are we going to address that? And I think your book is going to be illuminating in that regard as well. And I'm very much looking forward to that. Would like to say I've been privileged, along with Dr. Polly and Dr. Fisher. Dr. Malakar is also one of my residents. So
Wow.
we have so many things to connect. I am so appreciating getting the chance to spend more time with you.
Oh, good. Oh, thank you very much. Thank you. So kind.
Again, blessings for you and your family, and thank you for the blessings you give to all of us in the cleft world.
Thank you. So kind. So kind.
So kind. Thank you, Professor Roberts. Okay, and finally, I would like to invite Professor Low to give his comment in this presentation for Dr. Fayyaz. Please, Dr. Low.
Hello, Dr. Fayyaz. Very nice to see your presentation again, and so happy that to know that you have so much experience of repairing the oral nasal fistula. As you mentioned in the slide, that really it's a long time that take a lot of experience to finally manage to successfully close all the fistula, the big fistula. Because I saw your picture that I said, wow, it's for me. I don't think that I could successfully close the fistula. Now, I would like to have your final comment that I think for the take-home message for the audience, that you use the palatal tissue, if you can dissect palatal tissue, and you also use several regional tissue to close the fistula. I would like to have your last opinion that please mention all the regional tissue. As I remember in your presentation, you use pharyngeal flap, buccal-mucosa flap, postnatal flap, if I remember correctly.
Yes.
And also, can you just a tongue flap, because I think all this regional flap is very helpful. I can see in your presentation that you can even use only the regional tissue without free flap, and then to close such a big fistula. Can you repeat that again?
Actually, what I would like to share is that most important point that we have to close the nasal layer adequately whenever we want to close the fistula. Most of our colleagues, they find difficulty in closing the nasal layer. There is always ample tissue available on the sides of the palate to close and to bring the tissues in the midline. And we also need to learn how to dissect the pedicle so that the mucoperioptic flap can be made more mobile. It can move to the left side, it can move to the right side. So these maneuvers can help any surgeon to use, even if there's only one mucoperioptic flap, to cover the whole of the palate. But whenever I feel deficient, I will go for vaccinator because it is one stage procedure, or I can use tongue flap because it can be easily done by most of the colleagues. The only thing that the tongue have to be detached after 2 to 3 weeks. A free flap I have never used, and I sincerely feel that for the palate, there's a lot many tissue available within the oral cavity that the free flap is not needed.
Thank you. That's a very helpful information for all the audience, including me. Thank you again.
It's my honor. It's my honor. It's my honor.
Yes, thank you, Professor Low. I think the whole audience are very curious and are very lucky to have the presentation tonight. We have 2 more questions for Professor Fayyaz. I think time, is it okay for you? Okay.
Yes, yes.
Dr. Urego is asking about how do you tether your pharyngeal flaps to avoid sleep apnea in case in the future? And do you scope the patient before the pharyngeal flap in your surgery?
Yes, because actually I will mention Professor Low's paper, because when he described that the small, medium, and large size of the pharyngeal flap. Generally, our policy has been to use only 60% of the width of the posterior pharyngeal wall. So that means we leave 20% on the right side, 20% on the left side for breathing. We routinely do pharyngeal flap even in our cleft missions. Maybe for the last many years, we have done maybe more than 1,000 pharyngeal flaps. Only in 2 patients, I had to open the space behind the pharyngeal flap on the right side. Otherwise, our patients are very much fine. And the tip I can share is, we have a routine when we operate the patient. Patient goes to the recovery after the surgery, and patient is extubated in the recovery. The recovery person will make sure when the patient is awake, he will close the mouth, and he will examine the patient can breathe through the nose. If the patient can breathe through the nose comfortably, only then he will shift the patient to the inpatient department. If there is any problem, he will call us, and then we can have a good look what is the problem. Generally, using 60% of the width of the pharyngeal flap, you never will have obstructive sleep apnea.
Okay, thank you, Professor. We have the last one questions. And later, I would like to invite all our audience in front of the screen to show you a smile. I would like to invite you to give a group photo together. So, okay, the last one question is that, Professor Fayyaz, do you think the clap surgery has a significant effect of the facial growth?
Yes, I still remember in 2005, I had a patient who had bilateral complete cleft lip, bilateral complete cleft palate with protruding premaxilla. And I tried my level best to repair the bilateral cleft lip in one stage. The result was very good. Then I repaired the palate after 6 months. The speech of the patient is very good, no speech therapy. But as the patient grew, the maxilla growth was retarded. So for many, many years, now we have made a policy. If we get a patient with bilateral complete cleft palate with protruding premaxilla, if the patient can report to our center, we will refer to our orthodontist and she would do the name. And after 3 months or 4 months, the premaxilla is level with the lateral segment and we can go for the lip repair. If the patient reports late, maybe let's say after 3 months or maybe 2 years or after 3 years, and he or she has not been operated, we would go for adhesion, bilateral adhesion. And the adhesion we learned from Dr. Kai Fang Hung when he visited us in 2004 with Philip Chen. And I wantedly put a patient for adhesion because we did not know how to do good adhesion. Now, when we do lip adhesion, on one side, the side which is more wider, we will close the nasal layer along with the lip adhesion. And then after that, and we usually do not remove the sutures because we use Vicryl and these sutures are left as such. And after 1 month, the sutures, they are almost dissolved. Then after 6 months, we will go for the palate repair. When we do the palate repair, we close the nasal layer on the other side. So then after usually 2 to 3 years after the adhesion, we will go for the final lip nose revision. By that time, the premaxilla has gone back. It is almost in level with the lateral segment. And when we do that lip repair, the tissues are already very near to each other. So we don't have to dissect much. So the damage to the growth of the maxilla is probably reduced. So we are trying to get data of our patient who we did the adhesion, the palate repair, and the final lip nose revision. Maybe after 2 to 3 years, we would be able to give sufficient data to validate whether this procedure does affect the maxillary growth or not.
Okay. Okay. Thank you, Professor Fayyaz. Okay. And now I think it's a joy time. So please, all our participants, could you please to show your smile in front of the screen? I would like to capture for all of you. Yeah, because today is a very memorable day. Yes, we have a lot of master in this webinar together with us. May I count to 3? I will click my capture click. So we have a 3 page of the audience tonight and today with us. In the first page, okay, 1, 2, cheers, please. Thank you. And for the second page, yeah. Okay, please. 1, 2, cheers.
Cheers.
Thank you. For the third page. Okay, 1, 2, cheers. Thank you very much. Okay, I have to conclude tonight's webinar. So thank you, Professor Fayyaz, for your wonderful lecture.
Thank you. So kind.
Yeah.
So kind.
And wait a minute. Later. I have to announce announce our next presentation in ICC 7 days later. Another topic about facial trauma. We invited the Professor Chang to give us a special topic. He will present the evolution of the orbital reconstruction. So welcome all of you join the webinar as well. And thank you. Have a good day and have a good night. See you next time.
Thank you.
Bye-bye.
It's okay. Bye-bye.
Bye.